Good morning, ladies and gentlemen, dear friends. It's my pleasure to welcome you to this keynote lecture session on global health for development. I believe one of the core events of this World Health Summit. I'm Ilona Kickbush. I'm the director of the Global Health Program at the Graduate Institute in Geneva. And I would also like to welcome you on behalf of my co-chair, Christina Mitchell from Monash University. We too will be guiding you through this session. First, a bit of explanation about the participation. Sadly, the Minister of Health of Rwanda could not join us, but we are absolutely delighted that Madam Sherry Aitai, the Honorable Minister of Health of Ghana, has been able to join us for the discussions. And as you know, Ghana is a country that has been a leader in many areas of health development. And so she has agreed to join us at rather short notice to comment on the presentations that you will hear in a minute. The program has been put together in a very special way to actually allow you to also reflect on some of the key challenges we do have in relation to global health and development, and showing how global health contributes to development, but also how development obviously contributes to global health. We will have a strong focus on the issues of equity and the social determinants. We will hear about the importance and the movement for universal health coverage, and we will be reflecting on the responsibility and the role of the private sector, and in particular the pharmaceutical industry, in moving the global health agenda forward. I think with that we have a really critical triangle that will help us move the agenda forward. So without further ado, I will introduce our first speaker, who actually, at least in the global health world, needs absolutely no introduction, Sir Michael Marmot. Sir Michael, of course, has done groundbreaking research in relation to the social gradient on health, which has led to a revolution in the equity agenda. He was then the chair of a groundbreaking commission of the WHO, the Commission on the Social Determinants of Health. And I think one can say without question that the deliberations and the results of this commission have shaped the global health debate over the last 10 years and have influenced many countries, but also many organizations, to revisit the way they structure and they approach health policy making. It has also opened our perspective how much other sectors, how much other policies contribute to health. And it has, of course, also shown us how political global health, how political any public health action is. And some of you might remember what the Commission said, that basically equity depends on money, power, and resources. And we know that that is either negotiated politically or fought for politically. Sir Michael has gone on to apply and advise on how to write policies based on the social determinants. He has met many ministers, many prime ministers and presidents to take this agenda forward. He has been asked by the regional office of the WHO to study the health inequities in the European region, and just at this year's regional committee, he presented the groundbreaking study on the equity issues in Europe. And he has advised the UK government also in relation to their policies on equity. So nobody better than Sir Michael to speak to us on these issues. We've worked together for a long time, and that's why I'm always delighted if I can introduce him. Michael, please.
Thank you, and it is a great pleasure to participate. Professor Ganton said to me this morning in welcoming me that this topic used to be completely beyond the pale. In Germany, he said 20 years ago, it was only some fringe group that would talk about equity or social determinants. I'm slightly uneasy at the idea that this is now acceptable to the establishment. But I think it is important that people take this seriously. And one of the questions when we published the report of the Global Commission on Social Determinants of Health was what would happen to that report? Would anybody listen? Well, one indication that people are listening was, as Ilona said in introducing me, the regional director of WHO for Europe, Susanna Jakob, commissioned me to lead a review of social determinants of health and the health divide in Europe. And I want, because that's new and it's a new report, I want to present some key findings and messages from that. That's not to say that I think this only applies to Europe. The WHO Commission was global in its scope. And I already know that the Pan American Health Organization is taking this same approach to apply in the American region. We know that India is taking this approach. So it's not just for Europe, but what I will show you today comes from the European review. The reason for such a review, we said, was that health inequities persist within and between countries. This is the health divide in male life expectancy in the European region. And you remember the European region includes all of the former Soviet Union. So it stretches to the Bering Strait. You can practically reach Sarah Palin from Europe. It goes so far east. That's not funny. And you can see that the life expectancy gap for men is 17 years. The rest of the world thinks that Europe is the rich region of the world and couldn't possibly have the same problems that the rest of the world has. But Kazakhstan, Kyrgyzstan look in health terms like they could be in sub-Saharan Africa. And the Russian Federation, as I said, life expectancy 17 years shorter than in Israel, Iceland, Sweden. And of course, in Russia, they don't die of communicable disease. It's not dysentery that's carrying people off. It's heart disease and violent deaths. And we can see the persistence of health inequities within countries, even in Sweden. So Sweden looks at the top of the life expectancy chart there. But if we look at the social gradient in mortality or life expectancy by education, primary education is the bottom one, then secondary, and then higher education. In fact, for men, the gap has increased by 1 year, and for women, the gap's increased by nearly a year over a 20-year period. So even in Sweden, persisting health inequities and increasing health inequities. And in the Russian Federation, expectation of life for people with university education has been increasing, for people with primary education has been decreasing, so the gap has been increasing. So rich countries, poor countries, healthy countries, less healthy countries, we're concerned about increasing inequities within countries and the huge inequities between countries. And looking at the between country differences, life expectancy by gross domestic product at purchasing power parities, what you see here really are two clusters. Look at the richer countries. There's simply no relation between income and life expectancy. It's a cluster. If you go from Slovenia out to Luxembourg, a huge difference in income, and no difference in life expectancy to speak of. So getting richer for a country is no guarantee of getting healthier. Once you get above about $10,000, $20,000, $15,000 per capita purchasing power parities, there's no life expectancy gain for getting richer. Some are healthier than others, but it's not income. Then there's another cluster, and there's not much of a relation in that second cluster either. They're poorer, and they have worse health, but amongst that second cluster in the European region, you can see a huge variation that's not strongly related to national income. So it'd be quite good to get enough money for a country to get from the bottom cluster to the top cluster, but it's not degrees of money that seems to be the important issue. We think we understand a great deal about what the important issues are: inequities in power, money and resources, and the conditions of daily life, the social determinants of health. And that's why we say that these health inequities are unnecessary, avoidable, and unjust. In case you're wondering, and I'll show you in a moment, where this background photo comes with a cloth cap, these are the indignados, the young people on the streets of Madrid, where unemployment for 18 to 24-year-olds is 52%. And these young people don't like it. We have politicians in my country who think that unemployment is a lifestyle choice. It's such a lifestyle choice that these people are out on the streets saying, "We don't like it. You've betrayed our generation." And I would say that youth unemployment is a public health emergency. Because if these young people get thrown on the scrap heap as they leave school, they never recover. That's why they're angry. And so the key principles that underlay the Global Commission, which we called Closing the Gap in a Generation, that social injustice is killing on a grand scale, applies to the European review. We said with the Global Commission that empowerment, achieving empowerment, was right at the center. And we thought of empowerment as material conditions, psychosocial, having control over your life, and political, having voice. The young people in Madrid who take to the streets because they feel they don't have a voice. And we said, in response to people who say, where is personal responsibility in all this? We say personal responsibility is right at the center, but we have to create the conditions for people to be able to take control of their lives. So the themes from the European review was we emphasized human rights. We said more this time than we had in previous reviews about resilience, about the ability to respond and deal with the onslaughts, and resilience of individuals and communities. We talk about every stage of the life course, and I'll show you one slide particularly about protecting future generations, the intergenerational transmission of equity, and joined up action is needed. And we emphasized, and this was a phrase we coined for the English review of health inequalities, proportionate universalism. And by that we mean there are clear advantages to universalist policies, policies that apply across the social spectrum to all of us. But, we said, we have to have effort proportionate to need. So in Britain, for example, the National Health Service still is a universalist service. It applies to everybody. But we don't put the same effort into everybody. Happily, some people need it less than others. It's there for all of us if we need it, but effort is proportionate to need. So that's the idea of proportionate universalism. We had 4 major areas of recommendations: life course stages, wider society, macro-level context, and health and social systems. We emphasized good quality parenting, family building, and gender equity. And we said there's much that can be done. The evidence shows clearly that children born and being raised in families in poverty have worse early child development, physical development, cognitive and linguistic development, and social and emotional development. And when I said joined-up action is needed outside the health sector, look at these figures on child poverty. Compare Latvia and Sweden, for example. Before taxes and transfers, poverty levels, child poverty levels, and poverty is defined as less than 60% of median income. So in Latvia, before taxes and transfers, poverty levels are around 35%. In Sweden, they're around 32%. After taxes and transfers, poverty levels in Latvia have gone from 35% to 25%, and in Sweden, they've gone from 32% to 12%. In Slovenia, not a rich country, they're even lower. Clearly, the government, presumably reflecting the will of the population in a democracy, has decided in Sweden and Slovenia and Norway that child poverty is unacceptable. So taxes and transfers are used to reduce child poverty levels. In the United Kingdom, we do that less. In Poland, less. And Latvia, less still. It's not that we don't have the money to reduce child poverty. We've decided we don't want to do it. It's not a political priority. The effect of that is to damage children's development. And that, in turn, will have an adverse impact on health inequity. And I think it's incumbent on us in the health sector to be advocates for better policies that will have a beneficial effect on health equity. One minister in the European region said, health is a matter of personal responsibility. We don't think WHO should have anything to do with this social determinants business. And I said, what about the children? Are you going to blame the children? They were so irresponsible as to choose poor parents. It's their fault. Blame the children because they were irresponsible in choosing the environments in which they grew up. When in fact the Minister of Finance could improve conditions for children and have a positive impact on health equity. And of course that matters because poor early child development relates to worse performance in the education system, and people with less education have worse health in adult life all across the region. So we say provide universal good quality early years childcare, education, and as people get older, work. I said I wanted to say something about intergenerational equity. What this shows is a metric. It looks at the income of adult children compared to the income of their parents. If the income of the adult children exactly resembled the income of their parents, a country would score 1. If there were no relation between the income of children and the income of their parents, a country would score 0. So in other words, if the closer you are to 0, the more social mobility there is. The closer you are to 1, the more who your parents were determine what your income will be. So you can see Denmark is quite close to 0. Brazil is halfway towards 1. The US and the UK are probably closer to Brazil than they are to Denmark and Finland. And the point is, the greater the income inequality, the less social mobility. The greater the distance between the rungs on the ladder, the harder it is to get from one rung to the next. The greater the income inequality, the less the social mobility. So the kinds of income inequalities that we tolerate in the US and the UK and are present in a country like Brazil are harming the next generation, are making it less likely that children can get out of the difficult situations into which they were born. Working age. Key contributions of work and employment. Participation in the labour market. Those indignados on the street of Madrid. Appropriate income. Avoidance of adverse hazards. And a positive psychosocial environment. This is employment among 15 to 24-year-olds in the countries of Central and Eastern Europe and the Commonwealth of Independent States of the former Soviet Union. And you can see unemployment of 15 to 24-year-olds as high as 50% in some countries. That's Bosnia and Herzegovina at the top, and Kazakhstan at the bottom. As I said earlier, this is a public health emergency. The psychosocial environment at work. We emphasize imbalance between demand and control, imbalance between effort and reward, meaning putting out a large amount of effort and not getting appropriate reward, organizational injustice, being treated unfairly by the organization, and insecure work, all bad for health, and all follow the social gradient. So when we look at psychosocial stress and occupational class, those in very low occupational class are more likely to have imbalance between effort and reward and low control in the workplace. And the higher the occupational class, the less likely they are to have low control and effort-reward imbalance. The wider society. We talk about adequate social protection, social inclusion, and equity at older ages, and action across the social gradient. And let me show you just one example of how social protection policies can make a difference to the social gradient. This is the predicted probability of poor health by education. Low education, middle level and higher education, and you can see a big gradient. But the more generous the welfare spending, the narrower the social gradient. Countries that spend more on social welfare have narrower inequalities. So we say we need action across the life course, we need to build resilience, we need to reduce exclusion, and we need to strengthen communities. And the general theme with which we finished was do something, do more, do better. If a country is doing very little in terms of social policies that impact on health, do something. For poor countries, do something, it'll make a difference. If a country's in the middle of that range, do more. And if you're Sweden, you can do it better. Do something, do more, do better.
Thank you. It's a great pleasure to introduce our second speaker, Jeanette Vega, who's the Managing Director of Health for the Rockefeller Foundation. Dr. Vega started her career as a medical doctor in Chile, specialising in family medicine. She has a master's degree in public health from the University of Chile and a PhD in public health from the University of Illinois at Chicago. She commenced in the Rockefeller Foundation in 2012, and as Managing Director, she leads the Foundation's work in health, including the development of strategy, implementation of the Foundation's current Transforming Health Systems initiative. She has a very distinguished record. She was Vice Minister for Health in Chile and led the country's 13-step agenda for equity in health. She's also served for the World Health Organization in Geneva as a director, where again she led initiatives in equity in health. Today, I'm very much looking forward to hear her speak on universal health coverage in the post-2015 development agenda.
Good morning. It's a pleasure to be here, and it's a pleasure to talk after Michael. We have known each other for several years. In fact, I was in WHO, and I was his counterpart from a WHO perspective when he was leading the Commission on Social Determinants of Health. So it's a bit weird to be talking today about the role of the health sector in improving health outcomes as opposed to the role of the government in improving health. So my presentation today will have three parts. First, I will discuss the connection between universal health coverage and sustainable development. Then I will discuss some definitional issues around universal health coverage. And then I will conclude by looking at the growing global momentum and interest in universal health coverage. And I hope that during my presentation I will convince you that universal health coverage should be the most relevant objective of the health sector to contribute to the Millennium Development Goals. So the slides that you see shows in the left side the three principles to take into account when countries design and implement reforms to improve access to quality care with financial protection, which is the definition of universal health coverage. The first principle is that health is a right, the right to everyone to enjoy the highest attainable standard of physical and mental health. If health is a right, then governments need to ensure that all citizens are entitled to this right, regardless of their social and economic conditions. Second principle, health is socially determined. In fact, we have heard that 75% of health outcomes depend on living and working conditions, which are the social determinants of health. But 25% of health outcomes depend on having a working health system that do what it is supposed to do, which is provide access to care with financial protection. The third principle is that health contributes to growth and development. Healthy population means higher labor productivity, higher returns to households from labor market participation. The right side of the slides shows the theory of change from increased access to health services to inclusive and sustainable growth. So when discussing the post-2015 development agenda, it is important to understand how different sectors contribute to the overall goal of well-being for all. I borrowed this slide from a very good friend of mine that is also on this audience, Suit, that is here. In terms of health outcomes, such as healthy life expectancy, the health sector is one of many contributors, and to maximize its contribution, it must work with other sectors that are the main drivers of change. For example, the education sector for maternal and child health indicators. However, the health sector has a unique and a specific contribution to make that no other sector can do, which is ensure access to quality and equitable care with financial protection to all citizens. This is the most specific contribution of the health sector to the goal of sustainable well-being. By doing that, the health sector is contributing effectively to the health outcomes that are also being part and being a consequence of other sectors. Once we realize that the health sector's specific contribution to overall well-being is to ensure universal health coverage, the question becomes then, how do we address the specific disease priority objectives? There has been a lot of discussion that if we have universal health coverage as an umbrella goal, then the specific objectives related to disease will be lost. Well, I would argue that the most cost-effective and efficient method to address vertical programs is to build integrated health systems, as opposed to focus on some specific vertical health programs. A good health system can address any specific programmatic challenge. And from a patient perspective, good results in terms of health coverage include prompt access to quality services that result in good health outcomes, decrease or cure of health signs and symptoms, and at an affordable cost. So, I've made the argument that universal health coverage is the specific health sector's contribution to sustainable development. I've also made the argument that universal health coverage links to other sectors and development goals. But what are the other criteria for a health social development goal that universal health coverage meets? First, universal health coverage is relevant for all countries in the world, rich and poor. Second, it appeals to politicians and to the people, to the citizens in every country in the world. And third, it can be measured, and there are several indicators to do so. Speaking of indicators, I want to insist in the exact definition of universal health coverage, which is also a motive for argument. The definition of universal health coverage that comes from the World Health Organization is that all people can access the health services they need without incurring financial hardship. We can measure access using proxy indicators, for example, utilization rates for different conditions and events. We can measure financial protection by using indicators such as percent of catastrophic or out-of-pocket payment and percent of people financially covered by any system. In fact, currently, the World Health Organization with the World Bank and several other donors and funders are working on a unifying framework to measure advances toward universal health coverage. Why is achieving universal health coverage so urgent as a global health goal? Well, first, because millions at present suffer financially when they use health services. This is a slide that shows the situation in different regions of the world. And you can see that in general, in total, around 100 million people around the world are pushed into poverty every year because of expenditures related to health care. Most importantly, millions miss out of needed health services with, as Michael showed, great inequities between and within countries in coverage of very basic essential services to improve health outcomes. For example, skilled birth attendants. Expenditures of medicines accounts for the largest components of out-of-pocket spending at public and private facilities in most low and middle-income countries, which directly affects the possibility of accessing treatment, for example, and that's what the slide shows, for secondary prevention of chronic diseases. Although most cardiovascular diseases occur in low-income and middle-income countries, few individuals, and many less than in developed countries with cardiovascular disease, use drugs, for example, for secondary prevention of cardiovascular diseases. Most importantly, country-level system factors affect the rates of drugs use more than individual-level factors such as age, sex, and education. So, why is UHC so important and relevant as a social development goal for health? Allow me to summarize. First, UHC is the health sector's urgent, inherent, and specific responsibility to ensure universal and equitable access to health services for improved health outcomes. Second, universal health coverage links to other sectors and enable healthy, sustainable development. Finally, universal health coverage is the right approach and ensures that health is understood as a fundamental human right. But this is not only aspirational, there has been significant progress in moving toward universal health coverage at both global and country level. So, where are we at this moment in the global discussion of UHC? The slide demonstrates that the most recent global attention to universal health coverage, starting with the landmark report of WHO in 2010, a follow-up World Health Assembly resolution, a focus on UHC in the Rio +20 Future We Want outcome document, a Lancet series on universal health coverage, and in late 2012, a UN resolution on universal health coverage. The universal health coverage goal has also been highlighted by the United Nations Secretary General. This summer, he published a report summarizing the various consultations and processes working to determine the post-2015 development agenda. For the health sector, the first thing that the Secretary General recognized was the importance of universal health coverage. Most importantly, in the ongoing international discussion, some countries are actively advocating and mobilizing for universal health coverage in the emerging post-2015 negotiations. This slide shows a statement from the Foreign Policy and Global Health Group consisting of Brazil, France, Indonesia, Norway, Senegal, South Africa, and Thailand. And so, in final conclusion, I'd like to draw on a commentary piece from my very good friend, Richard Horton. Universal health coverage is internationally and nationally recognized as the way forward for global health. For the post-2015 agenda, it is the only proposal that embraces the whole health system and puts rights and equity at the center of its vision. Specifically, universal health coverage emphasizes universal health access to comprehensive, high-quality prevention, treatment, and care, includes clear, specific, and concrete health goals, accelerating progress on the unfinished Millennium Development Agenda and incorporating all that was missing, such as non-communicable diseases, and considers targets and indicators specific to each part of the life course for children, adolescents, adults, and the elderly. Muchas gracias.
Thank you so much for that wonderful talk. Our next speaker is Dr. Adrian Thomas, who is currently Vice President, Global Market Access and Public Health Policy for Janssen, the pharmaceutical companies of Johnson & Johnson. Dr. Thomas leads the Global Market Access, Commercial Strategy Operations and Global Public Health groups within this company. He's based in the United States and he has functional responsibility for health economics and pharmaceutical global pricing. He has a special interest in the areas of market access, pharmaceutical policy, public health and commercial strategy. His previous roles, he's worked with a number of other drug companies, including Schering-Plough and Eli Lilly. In a previous life, he trained as a clinician pharmacologist and vascular physician with experience in clinical trials design and methodology. He's a fellow of the Royal Australasian College of Physicians and the College of Medical Administrators. I didn't think I'd met Adrian before this presentation, but when I was talking to him before the meeting, I said, you seem vaguely familiar. And he said to me, yes, you tutored me in 1993 as a physician trainee and you were very tough. So obviously that prepared him for the pharmaceutical industry, and I look very much forward to his talk today.
Thanks, Chris. And a reunion, I should say, after 25 years or so was very pleasant this morning. You know, I'm here as representative of Janssen, which is the global name for all the pharma businesses of Johnson & Johnson, and talking about the future thinking towards how the pharmaceutical industry might address global public health and global health issues. I want to start off by acknowledging that this is, it's one perspective provided by myself, and like many of you, I've lived, worked, and participated in the delivery of healthcare in resource-challenged settings, and I lived in many geographies, and I've had the privilege to work for a number of very exciting institutions. And what I want to talk today about is how do we address the future of global health without addressing the notion of good and bad players, because I think that's where we have to fundamentally start to move forward. I think we also should acknowledge that there has been tremendous progress in global health. Depending on where you live, a 41% reduction in child mortality, since 1990, a 50% increase in mothers surviving childbirth. It's been around a little bit over 20 years since we had the HIV public health crisis globally, and we have a notable improvement in outcomes, again, depending on where you live, to this devastating illness. I think what we're seeing, though, is that the global health agenda and what the issues that the countries and individuals face is increasingly becoming an agenda of disparities. So there are many parts of the world where the focus is on life expectancy. It's on life expectancy because if you live in parts of sub-Saharan Africa and you face high rates of TB and HIV and hepatitis C and trauma and infant and child mortality issues, then if you don't focus on correcting those, you're leaving the low-hanging fruit on the tree. In other parts of the world, particularly the mature, higher-income countries, we've already achieved those massive gains, a doubling of life expectancy over the last 40 years. And the original research, which I think is still very strong and pertinent, suggests that for every year of life expectancy, you could expect to see around 4% of GDP growth associated with it. I don't think that's true anymore for our high-income established markets. What we're seeing there is we're pursuing gains at the end of the life expectancy curve. And to some extent, this is why we now see two clusters of worlds. One world which still has life expectancy gains to focus on, resource prioritisation, capacity and strengthening the healthcare systems. National strategies are required to address these. Then we have the other parts of the world where we really need to be focusing on healthy life expectancy. How do we focus our resources and energy against generating a society that can age to be more productive and less consumptive of the health dollar towards the end? To do that, we have to think differently. Janssen's a company which has a legacy in public health for over 50 years. Paul Janssen was the most prolific discoverer of drugs, over 80 drugs discovered and developed by one individual. But I think what we recognise today from Janssen is discovering drugs is not enough. It's not just about the pharmaceutical product. It's really around how do you create an environment where you can specifically discover, develop, through collaborations, products and technologies addressing specific public health or national health priorities, and then also have in place the appropriate systems to deliver those to patients. And I think that's very complex. If it was a simple problem, we wouldn't be here today discussing the challenges in the global health agenda post the 2015 MDGs, but we are. And having just brought a multi-drug resistant TB product to the world, the first new product in over 40 years to be specifically developed against that indication, what we know is if we want to actually see that product transform the lives of patients who have MDR-TB, we have to acknowledge a couple of things. One is our previous success rates in treating people with MDR-TB was not very impressive. 500,000 new cases in the world annually, approximately 80% or so concentrated in 4 or 5 high-burden markets, emerging markets and resource-challenged settings, very high prevalence in co-infected HIV patients, and somehow we managed to treat somewhere between 10 and 20,000 last year. So if you want to change that model, it's not just about the industry investing in technologies to bring new products to market, it's how do we have those products reach patients where they live? How do we bring associated technologies, diagnostics that allow us to say you are or you are not carrying a resistant bug? How do we increase the capacity and the competency of the healthcare system? I'm going to diverge here for a second and talk a little bit about the G20 summit, which occurred, and the previous work that was done by the business leadership, which is called the B20. We identified and acknowledged very clearly that we see energy, we see education and communication technologies, we see the innovative biotech industry, and we also see governments as being primary drivers for improvement in economic prosperity, but also in global health. So it's not just about the products, it's about the education, the capacity, the competency, the ability of the system to pull it through. Now, no talk from the pharmaceutical industry can go past on this topic without acknowledging some other things. There are challenges that we bring to the table. Affordability is a major issue for governments or for individual healthcare, no matter where you live. I would argue that if you have a 5% patient copay on an expensive end-of-life therapy in the United States, you are just as financially devastated as if you have an out-of-pocket self-pay person who has diabetes in Mumbai. So affordability is a challenge everywhere. And in mature markets, the affordability is on the efficiency side of the system. How do we get better outcomes at the same or marginally lower or higher cost? How do we improve those outcomes? In the emerging and less developed countries, the challenge is around how do we prioritize our resource allocation against those things that will drive most societal and economic benefit. And those are very, very different challenges. For the industry, it presents a particular conundrum. If we look at the model for HIV, for example, the model for HIV was we developed drugs against this devastating viral illness, and it's built on an established or developed market, mature market concept of widespread availability of viral load testing, resistance testing, very intensive application of expertise and resources. Let's not forget this, we're mobilized in an extremely short period of time. So this is not a 100-year legacy of of medical education kicking in on a topic. It was recognized in the 90s as being what it was. Drugs were developed, deployed, and implemented, and we had massive community upheaval driving that political will, funding, where we transformed a lethal disease to something which is now a chronic disease. And like many companies, we're currently developing a vaccine, and I'm sure the future includes a successful vaccine within the next 20 years, transforming the landscape of a disease. Now, I have a slightly different view, which is I think the challenge of applying that now to resource challenge settings. Let's go to Africa, let's go to Eastern Europe, parts of Latin America, Southeast Asia. We don't have widespread viral load testing. It costs $100 for a viral load test. The annual cost of first-line HIV therapy is around $100. So the impact of the health system of being able to do that testing would be devastating today because it's not ready for it. On the other hand, now that we have millions of patients on first-line therapy, we know without a doubt that there will be a significant cohort who will be failing therapy and require second-line therapy. Having just come back from Africa, I can tell you the deployment and availability of viral load testing, simple technology to take for granted here, is simply not adequate for those healthcare systems. So we have to start thinking about how do we have a different model for developing both new technologies, building the competencies and capacity within the system, and then being able to create access or pull those integrated products through to a very different health culture than we actually traditionally developed them for today. To do that, I think we need to recognise, now we talked about good players and bad players, we need to recognise that to advance this agenda, we have to move away from that language and simply acknowledge that people have, or organisations and people have, very different priorities and agendas, but that doesn't mean that we can't work together. I think we need to think differently. We have to engage people, because a lot of the conversation in the global health agenda doesn't involve the individuals we're treating, it's all on the stakeholder management side of it. People, governments, donors, NGOs, multilateral organisations and the industry in leveraging their specific capacity and ability to move the agenda forward. We have to think not just in investment terms, because when we talk about universal health coverage and we look across the world, and we saw a slide earlier on that shows you that spending more money isn't necessarily driving better outcomes, but you can see on the lower end of the life expectancy curve a fairly simple relationship between wealth and improvement of life expectancy. I would argue the clustering at the end is because you're chasing diminishing returns, and there's significant cultural and disease behavioural issues that are driving the diminishing returns. But having said that, I think we need to also look at how can we in fact focus investment in a smart way. So this is not about asking for more investment or greater investment, but can we look at national and clusters of national health priorities against specific diseases that are undermining simple life expectancy, and then towards the end of the life expectancy curve, focus national strategies around efficiency and effectiveness of healthcare. And that's a different model for our industry, and one that requires thinking about co-investment and risk sharing. If we think about the Janssen, it's a relatively small player in the global health or global public health, the healthcare industry globally. But we're part of a large, innovative industry that invests billions every year in drugs. And one can argue about whether the priorities driving those are correct. But we are also, as large players in the pharmaceutical industry, investing in global health diseases. I don't know of too many of the larger pharmaceutical companies that don't have specific targeted investments against TB, HIV, malaria, many of the intestinal and systemic parasites, sleeping sickness, other sorts of diseases. All of us are investing in the area of chronic diseases and end-of-life therapies and trying to advance the agenda against cancer. All of these things are worthwhile but have different objectives. If we look at MDR TB, because of where the disease burden lies, there is no question that there is no commercial traditional pharmaceutical market for that product. Does that mean that we wouldn't do it? No, we're bringing that product to market, and we have to figure out, having gone through the experience and seen the relative lack of success in treating patients who should be treated with these products, how can we de-risk that? Most of the larger pharmaceutical companies are already used to moving away from the old-style, what I call pharmaceutical model. That model was based on we discover and develop it in-house, we hold the intellectual property, we market it, we move on to the next drug. Today, we much more commonly rely on an open innovation model. Wherever it's discovered, whatever stage it's developing in, we're used to partnering with that. We need to partner with governments and other stakeholders to think about, could there be a broadening of that to include investment? Could we see donor agencies, governments, could we see companies getting together, could we see novel instruments like social development bonds being used to raise funding to de-risk the cost of discovery and development, which is the largest piece of the investment that the industry makes? On the access side, could we see incentives around disease payments? For example, most of the funding for resource challenge settings comes from third parties. Could we see incentives directly linked to improved health impact and outcomes? It's interesting to me that as I looked recently at something like sleeping sickness or chronic lymphocytic leukemia, two very different diseases, as you can imagine. I went to most of the emerging and least developed markets and looked for epidemiologic data on what is the true prevalence or incidence of these conditions. All next to it was red line text basically saying extrapolated on a population basis from the established markets. So we have a very poor understanding, I think, of the prevalence and incidence of disease in these countries, and we need to have better work on that. So what can companies like Janssen bring to this agenda? I think it's really around three pillars. One is each company will have a different area of expertise. We call them in our organisation disease area strongholds, but areas of focus. We have a global public health group, we have a cardiovascular metabolism group, we have an oncology group, we have an immunology group, and within that we specialise, and we specialise in the areas which we're able to scientifically move forward on with the most confidence. We also bring to this innovative thinking about how to create access models. Part of the challenge for us is bringing a product to market as step one, getting it to people as step two. We've already made the decision in global health that as we look at the markets which are faced by devastating burden of these diseases, we need to think beyond price, so we'll manage the price side of things, but we need to look at public health collaborations with people who are actually able to get the products on the ground. This means thinking creatively about regulatory reform, because many of these markets are years behind regulatory approvals for every other market that we move to. We need to see much faster progress on regulatory harmonisation so that those barriers go away. We need to think about how can we work with NGOs and governments and third-party stakeholders, and we routinely do this with organisations like Gates and so on, but how do we do that in a more systematic way around a disease area of focus that we can hook into? Where are the public health systems that we can hook into that are able to deliver these products? It's clear for us that we are not an organisation that is designed around high levels of efficiency. Not that we aren't efficient, but the larger part of the challenge that we face is development and discovery of novel and innovative products. We're not high volume manufacturers. So it's clear to us that we have to be able to remove barriers for generics companies to take on the role of high volume manufacturing and distribution. But how do we do that, in fact, when most of the larger generics players are exiting some of this space because the focus on price has got so extreme there's no margins in it? When many of the governments or super governmental agencies are ordering products, do it month by month, every 3 months, so you can't create the capacity to deliver a large volume you can't forecast. How do we change those incentives? We've made the decision as a company that we will not enforce our IP rights for global public health products. We've given our IP to generics companies, but the worrying trend that we see is that there's no incentive for generics manufacturers to move into this space. And in fact, if you look at many of the larger generics organisations, they're moving into the innovative space. So we have to do something about that because that will become a supply issue. The third thing that we're doing is we're recognising that we have a role as a convener. We are not the only player in this space, and it would be ludicrous for me to stand here and say we're going to solve the world's global health issues by developing new products. What we need to have is an understanding and common agreement around what are the priorities, what do we need to deliver? We need to deliver development programs that generate evidence on our products that's relevant to the different settings in which you plan on using them. So, for example, as we today routinely do companion diagnostics and diagnostic testing for our oncology products, looking to actually segment patients out for those who receive the highest value and exclude those who are at risk. If those technologies are not available in these markets, then we cannot bring a product to this market that people will understand how to use. So if we're talking about a resource-limited setting with very simple diagnostics, where we might have to follow protocols of sequential care, we need to be able to understand what other trials that we should build with what endpoints to generate that evidence. The second thing is, although funding is always tight in every part of healthcare, and the recent austerity issues that every country has faced have contributed to a sharp focus on value, there is a lot of funding still available in the area of global public health, but it's fragmented. How do we bring that together? Industry funding, non-industry funding, how do we bring that together around aligned outcomes of what we're trying to achieve and make sure that we have in place public health impact measures that are truly relevant versus activity measures? But we do see it as the role of the industry to be part of that conversation and certainly to contribute towards investment in that area. Finally, we are launching, and I think every large company is doing this, but a number of on-the-ground pilot schemes. And so, for example, if I think about the world of hepatitis C, when I first joined the industry, which was close to 20 years ago, just after I survived Chris's training, I worked for a company that was investing in hepatitis C and had just moved, let's say, the surrogate cure rate from around 15% of success to 40% of success with a highly toxic regimen, including an injectable drug. So at that time, it was clear that that product would only play in a major way in markets which had the capacity and competency in that area and could afford those products. Well, those markets probably have maybe 5 million patients who suffer from chronic hep C. There's 170 million carriers of hepatitis C. And now we're moving to, in the last year and over the next 2 years, we will see products come out that will be one pill once a day with over a 98% cure rate. And this now opens up a major public health challenge. Given that in many markets, hepatitis C is almost an endemic illness. If we go to places like Romania, which has a population of 20 million, there are over 1 million carriers of hepatitis C, which we know that between 5 and 15% will die of liver failure or liver cancer. We don't know who's carrying it, so if you're having a baby or having a surgery or have recycling of instruments, you'll get transmission from person to person. There's absolutely no way you can treat 1 million people, even with a non-toxic drug, for 12 weeks if it's going to cost you, let's say, 2 billion euros. So we have to think differently there, and what we've done there is say, let's take a long-range view to this. Let's see this as a 40-year public health challenge, not an intellectual property protection period type challenge. And how can we contribute to a coalition that screens broadly, identifies where prevention should be taking place rather than treatment, looks at those who need treatment, treats those, and does it sequentially over a significant period of time. And guess what? They're already spending about 130 million euros a year on treating hepatitis C in Romania. They'll do that ad infinitum with no impact. Or you could say, let's amortize all of that, bring it forward, have an intensive 10-year period and a 40-year follow-up, and engineer that out of the healthcare system. So what I'm going to say, I'm going to finish up before I get evicted. But I want to say, look, the future presents an incredible opportunity to move beyond what I will argue is reasonable success towards the 2015 and moving beyond the 2015 MDGs. We do have a opportunity to reshape the global health landscape, to engineer out diseases, and to bring life expectancy to where it needs to be in the emerging markets and focus on healthy life expectancy. But it will only occur if we have innovation in funding and education and healthcare technologies, care delivery models, and partnering through technology delivery. Thank you.
As I indicated to you earlier, we have the great honor to have the Minister of Health of Ghana here with us. We did ask her, how do you pronounce your name? And she said, it's Sherry. So, Honourable Minister, I'd still like to address you with your formal title and ask you, you've heard these global players, you've heard how universal health coverage is being argued in the post-2015 agenda, you've heard how the global pharmaceutical industry is trying to change its model, you've heard the determinants challenge. And we thought it would be incredibly important to hear from you. How does that play out at the national level? Does this support the work you're doing? What have you already achieved that can be a model for others, or at least help them take the next steps? So please, you have the floor.
Thank you very much. Looking at all the presentations, I think I do agree that the theme running through its access to health services, education, and advocacy, and also looking at affordable cost for quality healthcare, and also skilled health service providers. And we believe that we must also strengthen our research, in order to attain universal health, coverage. I mean, basically, if I look at what is happening, especially in my country, my country is a developing country, then we are implementing the National Insurance Health Scheme. The National Health Scheme, we believe that we will be able to provide better, affordable health services to cover everybody in Ghana. You can also look at other countries in the African continent. With the National Health Scheme, government is contributing, almost about 80%. And we have taxes. We've leveled 2.5% tax on VAT, and we also have taxes from the oil revenue. We have taxes from road fund, to ensure that we'll be able to raise enough resources. And then also the Social Security is contributing about 2.5% towards the National Health Scheme financial budget. But I think there are still challenges because in my country, we have more people in the non-formal sector, and they don't contribute to the Social Security. So what becomes a challenge is the financial, backbone in order to achieve, competitive, health coverage for everybody. We support universal health coverage towards after 2015. I believe that in order to, close the gap in inequities, government must actually be committed. There must be a political commitment, that we will set some monies aside from our GDP to support health care. In Ghana, we also have free maternal and child health care on the National Health Insurance Scheme. We are also supporting 15 diseases, on the National Health Insurance Scheme. And also, we have, recently added, pensioners and the aged. They also, can get free Medicare. But this is not enough. We need to make sure that we have health centers across the country. So we are, putting up what we call community health centers across the country. These community health centers will be headed by what we call midwives, nursing trained in maternal health delivery. So at every vulnerable, community, you will have a community health program there. And at least we know that women and children, who are the priority on our agenda, will have access to good health systems. But at least currently we are also faced with a shortage of skilled medical personnel. Right now, the ratio of doctors to patients is 1 to 10,000. So we need to invest more money in training. We are putting up about 2 teaching hospitals, hoping that in every 5 years, we can come out with the training of 200 doctors, and then also training of nurses, other allied, staff to support the health delivery system. Because if you don't have skilled, health service providers, it doesn't matter how much money you put into universal healthcare, it will fail. So the environment, the technology, and also listening to my gentleman from Johnson & Johnson, there's a trend worrying, it is cutting across the African continent about quality of drugs. Because it doesn't matter how much, money you put into expensive diagnostic equipment. If a patient is diagnosed and then the patient is prescribed a drug, and it happens that the drug that you purchase is a counterfeit drug or fake. Recently, it happened in one country. A woman went to hospital, she delivered, she was attended to, and then she was prescribed some antibiotics. She went home, 2 weeks later, she died. And when it was investigated, it happened that the antibiotic was nothing but fake. So we need to have safety network in the drug supply chain. We must ensure that companies, pharmaceutical companies, will produce quality drugs so that it will help improve universal health coverage. If we don't have that in the pharmaceutical sector, then I think that sustainable development of providing equity and better healthcare to people on the continent, especially in Africa, will fail. We will lose billions of dollars, in trying to treat patients. Malaria alone is costing us over 12 billion manpower loss. So it is very important that we should do more research into quality drugs. We should improve the supply chain of drugs to support our universal health services. And then also we have to define, WHO should find a way that we can get safety network into the big manufacturers that provide drugs to the continent. Thank you.
Thank you, Minister, for raising a number of critical issues. I'll turn to Adrian first. Could you say a word or two about how you are involved in addressing the issues of counterfeit drugs, safety nets of this sort?
It's a hugely challenging issue, and it's not just Africa. It's in fact it's also a problem in the US and in Europe. Our policies are only to work with generics manufacturers and suppliers who are actually audited in accordance with their manufacturing processes. The issue is really once even a quality drug leaves the manufacturer's door, between it and getting to the patient, of course, it may have been diverted and a counterfeit product replaced with it. So it is a major issue. But what it really requires, as I said, regulatory harmonisation, and probably, as you've suggested, rather than safety monitoring, maybe compliance monitoring and auditing across the supply chain. I know there are a number of initiatives to create Pan-African supply chain network with a number of the large manufacturers, and that could certainly create a quality bar that's high, too high for counterfeiters to meet, but it remains a very, very significant issue.
Thank you. We'd like to open the floor now, and there are microphones, so please do take the opportunity to either inform us of some issues that are of concern to you or asking direct questions to any of the panelists. Who would like to make a start? Yes, please, and please introduce yourself.
Thank you very much. My name is George Patton from the University of Melbourne. I wanted to take up the theme of intergenerational inequality that Michael Marmot raised. So it's primarily a question for Michael, but it does seem to have a dimension that is relevant for the other speakers. You mentioned global youth unemployment as a public health crisis. I fully agree. This generation are entering adulthood with a whole range of other disadvantages. If they've had an education, they're likely to be carrying debt into adulthood. They're going to be the generation that carries the cost of climate change. But it seems to me that there's a really challenging political and economic dimension to this. We live in a rapidly aging world where economic resources, political clout, lies with the older generation, particularly in the global north. So policymakers, politicians, markets are going to be attending to their needs, and that includes the health market. So I'm really interested in your thoughts about what actions might be possible to address this intergenerational imbalance, which I think is a real challenge for us.
Thank you very much. Could we have one or two others, and then we will have the panel respond to be able to end on time. Please, Richard.
It's a question really addressed to Michael and to Jeanette. Jeanette, in your definition of universal health coverage, it was, I wrote it down so I hope I have it correctly, all people can access health services they need without incurring financial hardship. But then if we just reflect back to Michael's talk and social determinants, and indeed on your slide where you were saying 75% of health is determined by living and working conditions, how can we make sure that social determinants are not excluded from our concept of universal health coverage? And I know you feel very passionately about that, Jeanette, and Michael, I know you've written about that recently, but I wondered if you could just help us explore that potential tension in our thinking around universal health coverage.
Thank you. One more opportunity. Those are two big issues anyhow that have just come up. Someone's rushing there. Yes, please.
Fabian, medical student from Germany. One question more to like the pharma company. Why are you not trying to move to non-profit organization? Because for me, it's like there's a loss of credibility because of like there's a profit-orientated motivation behind many of your actions. Maybe if you would be non-profit, there would be no credibility for it. You also want to have like public health and global health in your mind. Thank you.
There is notions of global public goods, interesting from the young voices. So please, Jeanette.
Thank you. It's on. Okay. That's a great question, Richard, and a very important one. In fact, I think that there are two key issues to make sure that we make that connection. The first one, I think that what gets measured gets counted and then gets to be acted upon. So one of the things that is important is in this process of defining the core set of indicators to make sure that we measure progress toward UHC, there are some specific indicators that are more equity sensitive than others. And there are some data that show, based on WHS surveys, which are those. And in different countries, low-income, middle-income, and high-income countries, those indicators that are more equity-sensitive are different. So there is some work to be done there to put those equity-sensitive indicators and then to realize that it's not only income, that in some specific indicators, the stratifiers, the equity stratifiers are different than income. For example, infant mortality and maternal mortality are much more sensitive to education as an stratifier than income as an stratifier. So first piece, make sure that the equity component is included in the framework that is being developed to measure advances in universal health coverage. Second, and most probably important, we don't know really what is the contribution or what is the real weight of some of the specific indicators or the connection between some sectors and the indicators with health, and what are the pathways by which these two connect. So, for example, if I'm a health minister, I would like to know which are the critical indicators from other sectors that I have to monitor to make sure that the advances that I'm seeing are, in fact, connected to advances in other sectors. Let me put again the example of infant and maternal mortality. If I'm a Minister of Health, I cannot say that the infant mortality and maternal mortality advances are due to what I'm doing. I have to monitor and work with the Minister of Education, because improving in women's education is probably much more important than what I'm doing in the health sector. So the question becomes, in this framework of universal health coverage, what are those critical indicators from other sectors that we need to include as part of this core set of indicators? And that work also needs to happen. We are currently working with supporting WHO and the World Bank to do both pieces, and we hope they will be able to advance on that. But that is completely needed and urgently needed.
Thank you very much, Michael.
Well, to pick up where Jeanette left off on Richard's question, and as he said, I recently wrote a comment in a journal, I've forgotten the name for the moment, no, it wasn't British Medical, it was The Lancet. This is irony. And my concern is not with what Jeanette said. With what Jeanette said is absolutely fine. My concern is that when people rush off and think universal health care is all we have to do, that'll be the only health measure in the post-2015 set of indicators. When, let's assume, we could argue whether it's 25 or some other number, but let's just take Jeanette's figure and assume for the moment that 25% of health is determined by health coverage and 75% for other things. We're going to choose the one that's a quarter and privilege that one. And why are we going to privilege that one in the post-2015 agenda? Well, it's because it's the one that people in the healthcare sector care about most. But surely people in the healthcare sector should care about health. I went to the American Medical Association recently. I was welcomed there to talk about social determinants of health. They employ 900 people in Chicago, and they have a group of 25 on improving health outcomes. And I said, slightly rudely, given that they welcomed me there, only 25? Why aren't all 900 working on improving health outcomes? I mean, what more important thing could there be? But of course, medical associations work on improving conditions for doctors. That's their job. Whereas I think those of us in the health field, I'm a doctor, should be working on improving health. And the health sector is one important component, but there are others. Now, in the piece that I wrote for The Lancet, I suggested one way of not forgetting social determinants when thinking about universal health coverage is to make sure we've got a set of indicators to measure. And I proposed 3 and possibly 4. Early child development, the proportion of young people not in employment, education, or training. You heard me talk with some fire about that problem. And thirdly, the proportion of adults who are in poverty by whatever measure is prevailing in the country. And the fourth that I'd like to add is social isolation among older people. And I think if we could measure those four alongside whatever other indicators of health coverage we have, then we would have to focus on social determinants because they're absolutely vital. And when I was talking to the obstetricians and gynecologists in the US recently, I pointed out that on maternal mortality, the United States ranks 38th in the world, just after Turkey and just ahead of the Ukraine. And I said to these obstetricians, if you tell me that you provide the best obstetric care in the world, I'll believe you. But if I ask you to write on a piece of paper who's not getting that care, my guess is there'd be very little variation in what you wrote down on the piece of paper. Illegal immigrants, socially excluded, the poor. In other words, you can't deal with healthcare, exactly as Jeanette said, simply as a healthcare issue. You've got to look at the intersection between the social determinants and who's getting that high-quality healthcare. To come to the earlier question, you're asking correctly how we redesign the international economic and social order, and it's the right question. It won't surprise you to know that I won't do it before lunch. We might take another hour or so. But let me just say two principles. The first is that data and evidence really matter. My concern is that most of the discussions about can we afford to look after our older people? Can we afford to invest in early childhood and education are based on a complete absence, or worse, a distortion of available evidence. Complete absence or distortion of available evidence. And related to that, the second is there is enough money in the world to do everything we want to do. We are not limited by the amount of resource in the world. We're limited by its distribution, whether that's within countries or between countries. I showed you, for example, child poverty. That's not a resource problem, that's a distribution problem. That's a political issue. And if we look at differences between countries, we know that global poverty has plummeted. Now, that's largely because of China, because of the huge reduction in poverty levels in China. But global poverty levels have plummeted. It's really possible to do it really, really quickly. But we've got to have the evidence and we've got to have the political will to do it. So I see no trade-off at all between looking after today's and tomorrow's elderly and having the older people, and I have some vested interest in doing this, right, having a role in society and to lead flourishing lives with dignity, and investing in the next generation. There's enough money, there's enough knowledge. What we lack is the political will. I heard Alan Greenspan interviewed on the BBC this morning. Arguably, he was complicit. Arguably, he was the architect of the global financial crisis. And what did he say? I think austerity is the right policy. So he engineered the bubble and the crisis, and now he thinks austerity is the right policy. I was wondering why anybody was actually listening to him. I would like economics as if people mattered. When we have the debate about austerity or stimulus, it's not argued only in terms of gross domestic product. It's argued on the basis of the impact on the lives people are able to lead, and hence the likely impact on their health and health inequity. And I start from the proposition, the twin proposition, that if we base our discussions on the evidence and the fact that globally we have enough resource, then we can solve problems of intergenerational equity and dealing with old people with dignity at the same time.
Thank you, Michael, which clearly takes us back to what is called the political determinants of health, and it is always in phases of big social change that actually the political dimension of public health, or as Virchow would have said, of medicine, comes forward in the debate, and where we need to be much more prepared to enter that political debate and to provide data for the political debate while knowing that the decisions are political and not always based on the evidence that we do provide. I do think Michael's point also raises the fact that often in public health we say we need to speak to the finance minister and the finance minister needs to be convinced. But also the finance minister follows political decisions made in parliaments, made in either democratic debates or depending how certain societies are organized. And therefore that widening of creating a much better health literacy based on evidence of political decision makers and parliamentarians, I think becomes an absolutely critical issue in these times of change where the health issues are so much linked to the large social agenda as you have raised and as many people here on this panel have put forward. I'd like to ask the Minister if she wants to say a word or two how you bring those two agendas together in Ghana, and then we would end our discussions. Matthias said we had 5 more minutes. There you go.
Thank you very much. I think I will also support your idea of strong political will towards, equity in healthcare. But unfortunately or fortunately, suddenly, countries in Africa, we swing with the crisis in Europe and also in America. And these affect our political, resources. When crisis, especially when the Euro crisis was very strong, commitments to developing countries like the overseas development aids were actually cut down. It was very difficult for developing countries to get some support from bilateral donors to support our health agenda. Then we also have some crises that come to us in terms of sustainable development. We have issues on climate change, we have migration, we have long periods of drought, we have people moving from one place to another. That creates conflicts, in some sub-Saharan African countries. And then we have the issues of refugees on our hands, and we have to provide them with water, food, and also Medicare. So the whole system is complex. But I think that with a strong political will, and the support from our friends in the developed country, I think that development, sustainability should not only be limited to the rich countries. Sustainability should leverage towards the poor countries so that we can all have equity in health, and food and water. So this is what I think that we need to fight this together. And we will rely on our friends in the developed countries to support us with technology, knowledge transfer, and also, some resources so that we can build and strengthen our own health systems. Thank you.
Thank you very much, Madam Minister. That's a really nice closing statement that you've given. I think it also links to the opening lecture that we had from Kishore Mahbubani, indicating that we need new forms of global solidarity and governance to actually ensure equity. And I would like to add to what the Minister has said, that those new forms of South-South cooperation and support by some of the rapidly developing countries are proving also to be of critical importance to those that are not yet as advanced, so that we're also developing new models, particularly of this technical support and exchange. I'd like to say a big thank you to all the panelists and to the audience. I would like to suggest that Florian meets with Adrian to discuss this very critical issue that sadly we don't have time for now. And I'd like to thank you for your interest, thank all of you, and wish you a continuous, exciting World Health Summit. Thanks very much.